Seniors, beware. 9 popular medications that trigger rapid dementia. What if your brain could be shrinking right now, and not because of aging or genetics, but because of a pill you took this morning? It's not exaggerating. MRI scans, the same imaging used to detect brain tumors, have revealed that certain medications, commonly prescribed to older adults, are quietly thinning the cortex of the brain. That's the outer layer responsible for memory, decision-making, and personality. Even more shocking, these brain changes are happening in people who haven't even been diagnosed with dementia yet. In today's video, you'll discover 9 widely used medications that scientific studies have linked to faster cognitive decline, memory loss, and even structural brain damage. All the information we share is based on peer-reviewed scientific research from trusted medical institutions. We've included every source in the video description, so you can check them for yourself. Before we begin, don't forget to like this video and subscribe to our channel, especially if you care about protecting your memory, your independence, and your identity. After 60. Let's start with medication number 9. It's one you'll find in almost every family, even though it was never meant for long-term use. Medication number 9. Stomach acid inhibitors, the pills that quietly weaken your brain and bones. Proton pump inhibitors, known as PPIs, are drugs designed to reduce stomach acid. They're commonly used under names like omeprazole, pantoprazole, lansoprazole, and esomeprazole. Millions of older adults take them every morning to relieve heartburn, acid reflux, or ulcers. But what most people don't realize is that reducing stomach acid comes with serious biological consequences, especially over time. Your stomach acid isn't just there to digest food. It plays a critical role in absorbing nutrients like vitamin B12, magnesium, iron, and calcium. These nutrients are essential for your brain, nerves, muscles, and bones. When you suppress acid for months or years, your body slowly loses the ability to absorb what it needs. One of the most dangerous effects is vitamin B12 deficiency. Without B12, your nerves can become demyelinated, meaning the protective coating around them starts to break down. Think of it like a frayed electrical wire. The signals slow, the messages misfire, and symptoms begin to appear. Numbness in your hands, unsteady walking, mood swings, memory lapses, and confusion. Long-term acid suppression also affects the gut in other ways. Low acid allows harmful bacteria to survive and multiply, leading to more frequent infections in the intestines, lungs, and urinary tract. Inside the stomach itself, low acid triggers a rise in a hormone called gastrin. Over time, too much gastrin can lead to the growth of polyps, carcinoid tumors, and even stomach cancer. A 2020 review by Aaron Koyata, published in the journal Therapy, explained how long-term PPI use leads to hypochlorhydria, a state of abnormally low stomach acid, which disrupts nutrient absorption, immune protection, and hormonal balance in the gut. A 2022 meta-analysis by Piovani and colleagues, published in Alimentary Pharmacology and Therapeutics, looked at data from 1.6 million people. They found that using PPIs for more than 3 years increased the risk of gastric cancer by 82%. Most recently, in August 2023, a study in the journal Neurology followed over 5,700 older Americans and found that those who used PPIs for more than 4.5 years had a 33% higher risk of developing dementia. These numbers are alarming, but they don't mean you should stop your medication abruptly. They mean you need a conversation with your doctor, especially if you've been taking PPIs daily for more than 8 to 12 weeks. That's the limit most guidelines suggest. So what should you do instead? First, identify the original reason you started the medication. Was it for occasional heartburn or confirmed reflux disease? If your symptoms were mild or diet-related, You may be able to reduce or stop the medication with lifestyle changes. Avoid eating late at night. Limit caffeine, alcohol, fried foods, and chocolate. Elevate the head of your bed. Lose a few pounds if needed. These changes can significantly reduce acid reflux without medication. If you still need treatment, consider switching to a lower-risk alternative like an H2 blocker, for example, famotidine, also known as Pepcid. H2 blockers are milder and less likely to cause long-term complications. You can also ask your doctor about tapering your dose gradually instead of stopping all at once, which helps avoid painful rebound symptoms. In some cases, natural options may help support digestion, such as deglycyrrhizinated licorice, DGL, aloe vera juice, or drinking water with apple cider vinegar before meals, though these should always be discussed with your provider first, especially if you have other health conditions. The most important message is this: proton pump inhibitors were never meant to be taken forever. They're designed for short-term relief, not lifelong dependence. Medication number 8. Paroxetine. The antidepressant that may quietly turn against your heart and mind. Paroxetine might look harmless, a small pill taken for depression, anxiety, or even hot flashes. But this drug works by increasing serotonin in the brain. Serotonin is often called the feel-good chemical, and that's partly true. But serotonin also plays a role in how your heart beats, how your blood vessels react, and how your nervous system stays balanced. When paroxetine boosts serotonin too suddenly or too strongly, it can throw off that balance, especially in older bodies. One of the biggest concerns is how paroxetine affects your heart's rhythm. Normally, your heartbeat gently changes from moment to moment, a sign of good flexibility and health. But studies show paroxetine can interfere with this pattern, a measure called heart rate variability. In 2024, researchers led by Camila Marcondes de Oliveira analyzed several clinical trials and found that paroxetine significantly altered heart rhythm patterns in depressed patients. Some signals went up, others didn't, but the overall effect was one of disturbance, not stability. And that's not all. Paroxetine has a hidden talent. It blocks a liver enzyme called CYP2D6. This enzyme acts like a filter, helping your body safely process other medications. But when paroxetine shuts down that filter, it's like closing the drain in a sink. Medications like metoprolol for blood pressure, tamoxifen for breast cancer, or codeine for pain can either build up dangerously or fail to work at all. Imagine taking painkillers that never kick in, or heart pills that suddenly feel too strong. That's what happens when the liver's filter gets jammed. Older adults, especially women taking water pills, also face another quiet danger: low sodium levels in the blood, called hyponatremia. This can cause confusion, dizziness, seizures, and serious falls. Even low doses of paroxetine have been linked to this condition in postmenopausal women. And if you ever decide to stop paroxetine, do not go cold turkey. Unlike some antidepressants, paroxetine leaves the body quickly, which sounds good, until you realize it gives the brain no time to adjust. This can trigger what doctors call SSRI discontinuation syndrome, a storm of dizziness, nausea, strange shocks in the head, and deep emotional crashes. It doesn't mean your depression is coming back. It means your brain was too dependent on the drug and is now reeling from the sudden loss. So what should you do? If you're taking paroxetine, do not panic, and don't stop it without medical guidance. Talk to your doctor. Ask if a safer alternative, like sertraline or escitalopram, might be better for your age and condition. If you stay on paroxetine, have your sodium levels checked regularly. And if you're on other medications, especially for blood pressure, pain, or cancer, make sure your doctor knows so they can adjust your dosages. Paroxetine isn't evil. But in older adults, it often acts like a trickster, calm on the surface, but quietly stirring trouble beneath. That's why paroxetine deserves a second look, especially after 60. Medication number 7. Antipsychotics, a silent shortcut to death, stroke, and dementia in older adults. Antipsychotics, like risperidone, olanzapine, quetiapine, haloperidol, are powerful medications used to calm severe agitation, hallucinations, or delusions. They were originally developed for schizophrenia. But in nursing homes and hospitals, they're often used off-label for seniors with dementia who become restless or aggressive. The mechanism seems simple. These drugs block dopamine, a key brain messenger that controls mood, movement, and motivation. But dopamine is not just about behavior. It's deeply involved in motor control, blood pressure regulation, and memory. When we block dopamine too strongly, especially in aging brains, we disturb everything from heart rhythm to walking balance to cognitive clarity. And the consequences? They're devastating. A major review published in Drugs and Aging in 2023 found that antipsychotics are linked to sharply increased risks of stroke, pneumonia, Parkinsonism, blood clots, and early death, especially in older adults with dementia. These aren't rare events. These are common outcomes when these drugs are used long-term or without strict medical justification. What's worse, research suggests risks escalate significantly beyond 12 weeks of continuous use, making early tapering and routine reassessment crucial. One of the most shocking outcomes is how antipsychotics may accelerate the very disease they're used to manage. In a 2022 review published in Neurology International, researchers found that antipsychotic use in Alzheimer's patients often leads to faster cognitive decline, shrinking memory, shortening attention span, and increasing dependence. Weight gain is another creeping danger. A 2024 review by Marco Solmi and colleagues confirmed that medications like olanzapine and clozapine significantly increase weight, which leads to higher rates of diabetes, heart disease, and stroke, all of which compound the risks for older adults already vulnerable to those conditions. Worse, this weight gain happens early and predictably, within weeks of starting the drug. And for older adults already managing multiple prescriptions, blood thinners, diabetes drugs, sleeping pills, adding an antipsychotic may tip the scale toward disaster. Drug interactions can increase the risk of severe sedation, low blood pressure, confusion, and fatal arrhythmias. But if antipsychotics are so dangerous, why are they still used? Because in some acute situations, like when a patient is violent or delusional, there may be no other choice. But experts strongly recommend that these medications be a last resort, used at the lowest dose for the shortest time possible, and only when non-drug strategies have failed. So what should families and older patients do? First, if you or your loved one is taking an antipsychotic, ask why. Ask what specific symptoms it's treating, how long it's expected to be used, and when the next medication review will be. Demand alternatives: behavioral therapy, sensory interventions, music, touch, light. They all help calm agitation without altering brain chemistry. Second, insist on regular monitoring. If the drug must be used, track weight, blood sugar, blood pressure, and cognition, and never combine antipsychotics with sedatives, sleep aids, or opioids without careful oversight. These combinations can be fatal in older bodies. That's why for seniors, especially those with dementia, antipsychotics should never be the easy answer. They should be the absolute last resort. Medication number 6. Diphenhydramine, a common allergy pill that may silently harm your brain and heart. Diphenhydramine, often known by its brand name Benadryl, is a first-generation antihistamine widely used to relieve allergies, colds, and insomnia. But for older adults, this seemingly harmless over-the-counter pill may carry serious hidden dangers. Unlike newer antihistamines, diphenhydramine easily crosses the blood-brain barrier and interferes with acetylcholine, a key neurotransmitter responsible for memory, learning, and muscle coordination. As we age, acetylcholine levels naturally decline. Blocking it further with diphenhydramine can trigger symptoms like confusion, disorientation, drowsiness, and cognitive impairment, mimicking early dementia. This risk is especially concerning for seniors whose brains are already more vulnerable to neurological stress. Beyond cognitive decline, diphenhydramine can also affect the heart. At high doses or in sensitive individuals, it disrupts the heart's electrical signaling, leading to a condition known as QRS prolongation, a delay in the time it takes the heart to reset between beats. This can result in dangerous arrhythmias, seizures, or even sudden cardiac arrest. These outcomes are not rare. In a 2021 multicenter analysis led by Dr. Adrian Hughes, 15.6% of 863 diphenhydramine overdose cases resulted in serious outcomes, with seizures being the most frequent. Additionally, a nationwide study by Nemenik et al. In 2021 revealed that intentional misuse of diphenhydramine among adults over 65 increased by 230% between 2005 and 2016. Suicide attempts using the drug rose by 143% in the same age group. Part of the problem lies in how common and accessible this drug is. Diphenhydramine is not only sold as a standalone antihistamine, but also appears in many combination products for cough, cold, and sleep, making it easy to take accidentally in excessive doses. For those seeking alternatives, second-generation antihistamines such as loratadine or cetirizine offer similar allergy relief without crossing into the brain or affecting acetylcholine. If you're using diphenhydramine for sleep, consider natural methods like cognitive behavioral therapy for insomnia, CBTI, light exposure management, or relaxation techniques. Most importantly, always check medication labels carefully, especially with over-the-counter cold or sleep aids, and avoid combining diphenhydramine with alcohol or sedatives. Medication number 5. Bladder control medications, quieting your bladder but clouding your brain. Oxybutynin and tolterodine, two of the most widely used drugs for overactive bladder, might seem harmless. But while they quiet the bladder, they may also quietly impair your brain. These medications belong to a class called antimuscarinics. They work by blocking muscarinic receptors that trigger involuntary bladder contractions. The problem is, these receptors also exist in the brain, especially in areas critical for learning and memory. When you block them systemically, as these drugs do, you reduce the activity of acetylcholine, a neurotransmitter essential for cognition. The result, especially in older adults, can be confusion, memory decline, and even an increased risk of dementia. Scientific evidence strongly supports this concern. A 2021 systematic review led by Duong and colleagues, published in the International Urogynecology Journal, examined 18 studies involving patients with and without pre-existing cognitive impairment. The review found that oxybutynin was linked to cognitive decline in 5 out of 8 studies and tolterodine in 4 out of 7. In patients with Alzheimer's disease, oxybutynin was associated not only with worsened memory, but also with functional and behavioral deterioration. One study even linked solifenacin, a newer generation drug, to increased dementia risk in patients with diabetes. Not all bladder control medications carry the same risk. Duong's review reported that trospium, darifenacin, fesoterodine, and imidafenacin showed no association with cognitive impairment in any of the included studies. These medications tend to cross the blood-brain barrier poorly, making them a safer choice for older adults. A 2023 guideline update by Lou Christ and colleagues emphasized caution when prescribing these drugs to people over 65. They recommend starting with the lowest effective dose, closely monitoring for early signs of confusion, and discontinuing use immediately if cognitive symptoms appear. Patients with any history of dementia or cognitive concerns should avoid brain-penetrating antimuscarinics altogether. If you or someone you care for is currently taking a medication for bladder control, take a moment to check the name. If it's oxybutynin or tolterodine, consider speaking with a healthcare provider about safer alternatives like trospium or diphenhydramine. And if you've noticed any unusual forgetfulness, difficulty concentrating, or mood changes since starting treatment, don't dismiss it. Those may be more than just signs of aging. Let's stop here for now. Please stay tuned for part 2.